So, good morning everyone. So, now today's topic is pulmonary thromboembolism, and so you know there are venous thromboembolism is categorized as it can be due to deep venous thrombosis which can lead to pulmonary embolism. So, what is deep venous thrombosis? The blood clot formation within the large vein as we know, and pulmonary embolism, it results from DVT which can travel into pulmonary arterial circulation. 50% with pelvic vein or proximal leg DVT, they develop pulmonary embolism. Other causes are like air embolism or fat embolism or long standing surgery, orthopedic surgery, gynec surgery, all these things. So, why pulmonary embolism is important? Pulmonary embolism is the most common preventable cause of death in hospitalized patient. If you will not treat, the mortality is 30%. And 80% of pulmonary emboli occur without any warning sign. Therefore, the diagnosis is difficult and early treatment is highly effective for pulmonary embolism. So, next we will see what is the risk factor of pulmonary embolism. That is, as we know, Wernicke's triad, and it is due to stasis. It can be due to stasis, it can be due to endothelial damage or hypercoagulability state. So, why stasis and how stasis? Stasis occur if you know there is immobility or long travel, old age, major surgery, spinal cord injury, obesity. Endothelial damage also you know because of trauma or because of major surgery, or there can be hypercoagulability state. It can be congenital, it can be acquired. As we know, congenital or hereditary deficiency, it can be due to protein Cs deficiency, antithrombin deficiency, dysfibrinogenemia. The acquired cause of hypercoagulability we know all, that is cancer, pregnancy, oral contraceptive pills or hormone replacement, and in Apla's syndrome, that is antiphospholipid syndrome or chemotherapy. So, all these are risk factors for formation of thrombosis. Coming to what is the risk, major risk, and what is the minor risk factor. Major risk factor are major surgery like abdominal surgery, as I have mentioned before, orthopedic surgery, obstetric, that is late pregnancy or LSCS, preeclampsia, malignancy. Coming to minor risk factor, that is oral contraceptive pill, hormone replacement therapy, occult malignancy, congenital heart disease, all these are minor risk factor for pulmonary thromboembolism. This is otherwise known as economy class syndrome. So, what is economy class syndrome? If the passenger, I mean if you travel more than 10,000 kilometers, there is the risk of 4.8 cases per million, they get a chance of getting pulmonary thromboembolism or DVT. So, the risk increases by 18% of each 2 hours increment in the trip. So, pathophysiology, coming to pathophysiology, the pulmonary embolism, exactly what happened? Because of thrombus, because of occlusion, because of anatomic occlusion, there will be increased pulmonary arterial vascular resistance which lead to increased RV afterload, and it will cause RV dysfunction and increased right ventricular volume, which lead the leftward septal bowing to the septal movement. The septum is deviate towards the left side, and it will decrease the LV distensibility, which will decrease the preload. So, coming to diagnosis, how will diagnose? Yeah, so the symptom and sign, the symptoms are non-specific. The patient will present with dyspnea, chest pain, cough, hemoptysis and syncope. 80% of patient will present with dyspnea. Then what is the sign? The signs are, as we know, tachypnea, tachycardia, and the patient will have signs of DVT, and the patient can present with cyanosis. Coming to biomarker assay, as we know, D-dimer is the biomarker for pulmonary thromboembolism. Again, it is non-specific. So, what is D-dimer? These are fibrin degradation product, and negative D-dimer with low clinical probability is sufficient to exclude the pulmonary embolism, and this is 92% is sensitive. D-dimer should not be done if clinical probability is high. That means the probability, the clinically, if you are suspecting pulmonary thromboembolism, it doesn't, D-dimer should not be done. Then coming to investigation, that is chest X-ray. Chest X-ray, as we know, it is usually abnormal, but it is non-specific. So what we will see? We will see there are two signs, that is Western mark sign and Hampton hump. Also you can find cardiac enlargement or sometimes pleural effusion, 23% patient, 19% you will see pulmonary arterial enlargement. So Hampton hump, you can see this is a wedge shaped in the pleura, and there is right costophrenic angle. In the right costophrenic angle you can see the triangular shaped hump or wedge shaped infiltration. So this is a conical density with the base which is opposed to the chest wall. In ECG, what you will see, the most common sign, sinus tachycardia or RV strain pattern you can see. So this is S1 Q3 T3 T wave inversion, late transition, you can see the T3, you can see the Q3. So this is the ECG finding of pulmonary embolism. So you can see in the right pulmonary artery there is a huge thrombus which is occluding the whole RPA. We can do one VYQ scan or ventilation perfusion scan. So it can be an option when CT angio is not available. So what is the advantage? Advantage, we know there is no dose, there is low radiation dose and there is no requirement of contrast dye. The limitation, what is the limitation of VYQ scan? That is, it is unreliable in patient with COPD. Interpretation of how we will interpret the VYQ scan, it is highly dependent on the presence of pulmonary embolism. The sensitivity again 50 to 90% and specificity 20 to 60%. Normal results effectively exclude the pulmonary embolism. Multiple large mismatched result in setting of high pretest probability confirm the pulmonary embolism. What we can do else, that is pulmonary angiography we can do, that is it's very used, it's very less commonly used because it is invasive and the confirmation of you can confirm in indeterminate case. So how is the CT angio, what is the diagnostic, how will do diagnosis of pulmonary embolism? If you are suspecting pulmonary embolism, if pulmonary embolism you are suspecting, then you do one D-dimer. If D-dimer is more than 500 nanogram per ml, then you can do one CTPA. If CTPA, that is CT pulmonary angiogram, if CTPA is negative, then we can exclude the pulmonary embolism. If it is positive, yeah, we can confirm that. Next, coming to how stratify the risk. Yeah, we can stratify in several levels of risk of early death risk marker. Immediate bedside assessment for the presence or absence of marker allow the stratification. Coming to what are the markers, what are the principal marker for acute pulmonary embolism for risk stratification, that is markers of RV dysfunction. So we can see that is RV dilatation, RV hypokinesia, you can see the BNP and there can be elevated right heart pressure, or there can be myocardial injury, we can get through troponin T or troponin I. Coming to treatment. So what is the treatment? What is the acute treatment for pulmonary embolism? So again there are two things, patient can be stable or patient can be unstable. In hemodynamically stable patient, start anticoagulation, initiate anticoagulation immediately and achieve therapeutic level of anticoagulation within 24 hours. Failure to do so correlate with increased risk of clinical progression and increased risk of recurrence. Coming to what anticoagulant we are using, that is we know that is unfractionated heparin, low molecular weight heparin, rivaroxaban, apixaban and dabigatran and warfarin. Yeah, warfarin is generally begun at the time one of the what I have mentioned previously, one of the IV or subcutaneous anticoagulant you have started, after that you start warfarin because for bridging therapy, and the target or the therapeutic INR has to be 2. Coming to what is OPD and inpatient acute pulmonary embolism or OPD basis, how you will manage. If hemodynamically stable patient with normal biomarker, no significant comorbidity, younger age, that means less than 75 to 80 years, and low risk of anticoagulation complication, and the ability to adhere the prescribed treatment, so we can start anticoagulant for those patients. So coming to patient, if coming to hemodynamically unstable patient, if patient is unstable, what we can do? So what is unstable? Hemodynamically instability means there is elevation in pulmonary vascular resistance, pulmonary arterial pressure, right ventricle RV dysfunction, and decreased cardiac output, decreased systemic blood pressure. So in unstable patient, they require supplemental oxygen and may require mechanical ventilation. Fluid resuscitation may improve right ventricular function, again it can exacerbate pulmonary hypertension. In the setting of otherwise refractory hypertension, vasoconstrictor can be used. Because of their high risk of complication, mortality, patient with refractory hypertension due to pulmonary embolism should be treated by thrombolytic therapy followed by anticoagulation. So coming to thrombolytic therapy are streptokinase, urokinase and RTPA. So streptokinase, as we know, again the dose it has mentioned here. Again what we can do? We can do catheter embolectomy and fragmentation, an alternative in high risk pulmonary embolism patient when thrombolysis is absolutely contraindicated or failed thrombosis. We can try catheter embolectomy or fragmentation. Coming to IVC filter, they may provide lifelong protection against pulmonary embolism. We know what the complication is DVT, post thrombotic syndrome or IVC thrombosis. IVC filter can be considered in pregnant women with extensive thrombosis. So what is the poor prognosis marker? As we already mentioned, that is troponin level. Troponin level correlate in hospital mortality, but it does not, it significantly increased mortality in patient with troponin level if it is more than 0.1 nanogram per ml. Also we can, the prognostic marker also can be brain natriuretic peptide, that is BNP. Elevated BNP related to worst outcome, and low level can identify the good prognosis. So we can, we have discussed this one, the left towards septal bowing in the severe hemodynamic unstable pulmonary embolism patient where severe RV dysfunction settled. In echocardiography we can see there is RV dilatation. So the key of the acute pulmonary thromboembolism is the prevention. DVT prophylaxis in at-risk patient is quite effective for them. Thank you.